peripheral velocity. So I'd just like to spend a few minutes to describe for you some of the clinical trials that we have ongoing and describe for you the proteasome inhibitor franchise that we are developing at ONYX, which is now a subsidiary from Amgen. So within the proteasome inhibitor franchise at ONYX, we do now have two molecules in the clinic. We have Carfilzomib and Proteasome, which is an oral proteasome inhibitor. And both of these are based on the epoxy-ketone structure. They're both epoxy-ketone-based molecules. We've heard a lot about Carfilzomib. It's a selective proteasome inhibitor. It binds irreversibly to the proteasome, which allows for sustained proteasome inhibition. And it has minimal off-target activity. And that's evidenced in preclinical models where we see very little evidence of neurotoxicity. And we're starting to build up quite an extensive safety database. We have evidence that we can treat patients in the clinic for prolonged periods of time. Proteasome, on the other hand, is relatively early in the clinical development plan. It's largely in phase 1 and phase 2. And I'd just like to start by describing where we are with that molecule. We are starting an extensive development program in multiple myeloma, which includes studies in relapsed and refractory patients, and also in the frontline setting. And generally, these studies are in phase 1, early phase 1b, and the objective of these studies is to identify the MTD, either as a single agent or in combination with other therapies. So for instance, in relapsed and refractory settings, we're exploring the MTD as a single agent, or in combination with DEX, or in combination with POM-DEX. In the newly diagnosed frontline setting, we'll be looking at Proteasome with lenalidomide and DEX, or with cyclophosphamide and DEX, or with melphalan and prednisone. In addition to multiple myeloma, though, we're also going to be exploring the role of Proteasome in other hematological malignancies. For instance, in Waldenstrom's, where we already have some encouraging signs of clinical activity, but also in relapsed mantle cell lymphoma in combination with ibrutinib. Going beyond hematological malignancies, we also are going to be exploring the role of Proteasome in solid tumors. And in particular, there will be a study of the combination of Proteasome with Nexavar in frontline liver cancer, hepatocellular cancer, which will of course be very interesting for us here in the Asia Pacific region. I'd just like to briefly describe the phase 1 study of Proteasome as a single agent in hematological malignancies. This is a classical phase 1 study, dose escalation, the objective of which is to find a dose to take forwards into phase 2 of development. And we're exploring two different dosing regimens in this study. On the top, we have a regimen where we dose Proteasome on 2 consecutive days out of 7. And lower down, we have a schedule where we dose on 5 days out of 14. In the 5 days out of 14 schedule, we determine the dose for phase 2, which is 240 milligrams. In the 2 days out of 7 schedule, the dose escalation is ongoing. And it's still very early days in this study, and the patient numbers are quite small, but we are starting to see some encouraging signs of clinical activity, even as a single agent, both in multiple myeloma and in Waldenstrom's. In multiple myeloma, with the 5 days out of 14 regimen, we see single agent response rates of about 25-26% with Proteasome in the relapsed or relapsed and refractory setting. And in Waldenstrom's macroglobulinemia, we've seen response rates of up to 70% as single agent. So again, very encouraging signs of clinical activity, even though it's very early on and patient numbers are quite small. So moving on then to Carfilzomib, which we've heard a lot about already. We heard that Carfilzomib is already approved as a single agent for the treatment of patients with relapsed and refractory patients in the US. And this was an accelerated approval based on the 003A1 study, which was a single-arm phase 2 study. However, based on that data, we've embarked on a very extensive clinical development plan, and now we have 4 phase 3 studies ongoing. And the development was quite rapid. In particular, 2 of those studies were initiated within 4 years of the first time in human study with Carfilzomib. And these studies were the FOCUS study and the ASPIRE study. And the FOCUS study is a study in relapsed and refractory multiple myeloma, and the ASPIRE study is a study in relapsed multiple myeloma after 1 to 3 prior therapies. In addition to those 2 studies, we've also initiated 2 further phase 3 studies, which are both head-to-head studies comparing Carfilzomib against Proteasome. The first of those is ENDEAVOR, which is again a study in the relapse setting, but we also have CLARION, which is a study in the frontline setting for newly diagnosed patients who are transplant ineligible. And I'll describe each of these 4 studies in a little bit more detail in the next few slides. I would add at this point, though, that we also have some other programs with Carfilzomib in clinical development. We do have a study looking at solid tumors, in particular non-small cell lung cancer. And we also have plans to initiate a study in lupus nephritis, so in immunotherapy, immunomodulation. So the first of the phase 3 studies is the FOCUS study. And this is the study in patients with relapsed and refractory multiple myeloma, a study very similar to that for which the product is already approved. For us, this is a very important study because this is a study that's being discussed with the agency in Europe, and this is the study that will help us, hopefully, to get approval in Europe. In this study, patients with relapsed and refractory multiple myeloma are randomized to either treatment with single-agent Carfilzomib or to best supportive care, which in the territories being considered for this study was generally corticosteroids plus or minus cyclophosphamide. Patients are randomized 1-to-1, and the primary endpoint for this study is overall survival. This study is fully enrolled, and we expect to get final results from this study in the first half of 2014, so very soon. The next study is the ASPIRE study. This is a study in patients with relapsed multiple myeloma after 1 to 3 prior therapies. 792 patients randomized in a 1-to-1 fashion to treatment either with Carfilzomib, with lenalidomide and dexamethasone, or to lenalidomide and dexamethasone alone. In this study, the primary endpoint is PFS. Again, this study is fully enrolled, and we expect to get the results of an interim analysis in the first half of 2014. The next study we have is the ENDEAVOR study. Again, a large study, 888 patients, randomized 1-to-1. Patients with relapsed multiple myeloma to receive treatment either with Carfilzomib and dexamethasone or bortezomib and dexamethasone. So this is the first of our head-to-head studies. And as was described earlier, this is a study where we've been able to increase the dose of Carfilzomib. Previous studies were at the 20-27 dose level. Here we've gone up to the 56 dose level, as was described by Dr. Orlovsky, based on data which showed that when the duration of administration of Carfilzomib was increased from a 10-minute infusion to a 30-minute infusion, the tolerability profile was significantly improved, which allowed us to test these higher doses. Also importantly in this study, in addition to it being a head-to-head study, Carfilzomib against bortezomib, this study will also include a cardiac safety sub-study where patients will undergo serial echocardiograms, and this will help us to better understand the safety profile of Carfilzomib as we go forwards. The last of the 4 phase 3 studies is the CLARION study. Again, a head-to-head study of Carfilzomib against bortezomib. This time, almost 900 patients, frontline, newly diagnosed, transplant ineligible, randomized 1-to-1 to treatment with either CMP, so Carfilzomib, melphalan, prednisone, or BMP, bortezomib, melphalan, prednisone, again with a primary endpoint of PFS. So this is a study in patients who are transplant ineligible. Obviously, we're also very interested in patients who are eligible for transplant. And we have some very interesting data with Carfilzomib based on ISTs. We heard about data from Corda in the NCI, and we also have very exciting data from Dr. Jakubowiak, which have shown very impressive response rates in patients achieving levels of NRD negativity. There's also another study ongoing, which Dr. Orlovsky mentioned, ECOG study, which is comparing induction therapy in transplant-eligible patients, either with BRD or with CRD. And in this study, patients undergo an induction period of 9 months, followed by a second randomization, and then a maintenance component, whereby they're either treated for a limited duration of 24 cycles or until progressive disease or intolerance. Again, we're very excited about this study because of the initial part of the study, where the patients are randomized to treatment either with CRD or BRD with a delayed transplant. And one of the endpoints for the study will be the response rates, including NRD negativity at the end of this period of induction. So just to conclude then, following the approval of Carfilzomib based on a single-arm phase 2 study, we've embarked on a very extensive clinical development plan. We started 2 studies very quickly, the FOCUS study in relapsed and refractory patients and the ASPIRE study in relapsed patients. And those studies are both fully enrolled, and we're very eagerly looking forward to data from those in the first half of 2014. Following from those 2 studies, we started another 2 phase 3 studies, which are both head-to-head studies of Carfilzomib against Proteasome. These are the ENDEAVOR study, again in relapsed patients, and the CLARION study in newly diagnosed transplant-ineligible patients. So I'd like to thank you for your time. I think we can take questions if there are any. Otherwise, enjoy your lunch. And thank you.